that means you're losing blood and you're not feeding. Actually, you end up being very anemic very fast. And anemia is a very bad state in someone's system, I would say.
So
because
anemia is a whole different devil on its own.
On its own. Because if your blood levels are low, and you know that red blood is the one which takes the oxygen to most of the body parts for food to be broken down, and you get nutrients. So if it's not adequate, then trouble arises. We know the white blood cells are for the body's defense system. So if they are down, then we are doomed. So that means the immunity will inevitably go down. So this cancer can cause a lot of complications. And obviously when your immunity goes down, you're even prone to other infections. As simple as they may appear, for this body, they are not very simple infections. They end up being very complicated, and the patient will lose life very fastest. So that's why we insist that patients should come to hospitals. If you feel you're not being helped, please move, ask for a referral to where you feel you will get the best care.
I think that is something else, Dr. Kabweru, that a very important point you raised, that the listener out there understands that you actually have a right to ask to be referred to a place where you think or feel you'll be managed more ably. If where you are, you feel you are not being given appropriate care, you have every right to request to be referred as a patient.
But also complications that may fall along this cancer, that actually it moves into the bones. Actually, sometimes people get fractures, but one of the worst complications will be bone marrow suppression. We know that the blood is produced from the bone marrow. And if they are suppressed or it breaks down, and that factory, then there is trouble in the city. So your body will become weak and will be attacked by anything. But even dying of anemia and a lot of infections will overwhelm the body. So if it moves into the brain, you know what happens, that actually you not live long, because the brain, you know, is the center of control of the entire body system and its functions. So you will have a lot of issues. So sometimes when you come early, you actually prevent these complications, and you actually live longer minus these complications, because some of these cancers don't kill you very fast. They stay in the body there, and then other things come and pick you up. Yes. So those are some of the complications that we should avoid by coming to hospital early.
Wow, wow, wow. Thank you, Dr. Kabweru. So I have interacted with you. You have checked me. You have diagnosed the cancer. Okay, someone has interacted with you. God forbid this happens to me. You diagnose them. How do we manage this patient?
Oh, thank you very much. When it comes to management, management depends on the stage and the type of cancer you have. If you come in early, or in between early and late, sometimes we do what we call adjuvant chemotherapy. What do we mean? We send you to the Cancer Institute. They first give you some cycles of those drugs that burn the cancer. They can give you a combination of chemotherapy, radiotherapy to shrink the cancer. Then you come back and we operate. Or sometimes if it's early, we may operate you and send you to cancer to continue with those other modalities. So surgery has a very big role in the management of cancer of the esophagus, either early or late. For early, it cuts away the tumor. We remove that part which has the cancer. Then we connect the stomach onto the tube so that you can have normal continuity like how it used to be. And that is one of the surgeries that we commonly do in Mulago. It's called esophagectomy. We cut away that esophagus with the cancer, and then we connect the remaining part of the esophagus with the stomach. And then 2, if we can't operate you and we feel we need to put other means, sometimes we stent. Stenting means we put this the SME, the self-expanding metallic stents. Those ones keep opening up the tumor so that they allow food to go into the stomach from the mouth into the stomach. But also they can recover in case you have a complication.
Dr. Kabweru, I think we can hold on to that for now.
Okay.
The information you are sharing is critical and I don't want us to rush it. We shall be back after this short commercial break. Thank you.
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Martyrs' Day is commemorated in Uganda on 3rd June annually. The day commemorates the 45 martyrs, both Catholic and Anglican, who were killed on the orders of Kabaka Muyanga II, then King of Buganda between 1885 and 1887, for their refusal to renounce their Christian faith. On Monday 3rd June 2024, Nebi Catholic Diocese will animate the celebrations under the theme, "But as for me and my household, we shall serve the Lord," Joshua 24:15. For the Anglican site, the Rwenzori cluster, which comprises of Munyoro Kitara, East and South Rwenzori, plus Masindi Diocese, will animate the celebrations under the theme, focusing on conforming to the truth of God's Word, Romans 12:1-2. Join us for the live broadcast of the celebrations on Monday 3rd June at Namugongo.
This message is from the Ministry of Health with support from partners.
You are watching the DOCtalk Show.
Welcome back from that short commercial break. This is the DOCtalk Show, brought to you by Quiz Malay Productions and proudly sponsored by the Ministry of Health and its partners. We left off for the quick break with Dr. Kabweru, and he was telling us about the various modalities they use in managing cancer of the esophagus. And he was telling us about a stent, which is quite interesting, that along the way, as we develop cancer of the esophagus, you may find the esophagus slowly getting blocked off. And what he was passing on is that they have special devices they can actually insert within the esophagus to enable it to do what? To open up slowly over time, to allow food to actually continue passing through as well. But I don't want to cut him short. He's the content expert of the evening. And Dr. Kabweru,
Yes.
Please continue.
Thank you very much. So we're discussing about the stenting. Stents have different types, and the commonest that is latest, what we call the SEM is SIMS, the self-expanding metallic stents. And we, depending on the size and the length of the stricture, that determines the type, and then the type of the stent we are going to use, or how long it should be.
The client out, the person out there watching, yes.
Yes, that narrowing, how long the narrowing is.
Yes.
Also gives us what length we should use. Because for instance, if you have like a length of 8 centimeters that is blocking off, that is narrowed, then you need to get a stent that is around 10 or 12 centimeters, so that 2 centimeters above are free of the margin, and then 2 centimeters below, so that it helps to hold, but also to cover off properly and allow things to go in. Now, there are different types. Those ones that are covered with a membrane, and those will be the best, because if they are covered with a membrane, it means the tumor won't grow into it, and even when there is an opening between the esophagus and the airway, it will not allow food to go to the airway. So that covered stent is very important. And it's very key.
Dr. Kabweru,
Yes,
I am enjoying listening to you personally,
yes.
but
The patients,
some of the people watching out there,
yes.
you've beautifully described for us what stenting is going to do.
Yes.
I think,
And why important we talk about the covered one, so that they are not duped into just to be put into a stent, and then they have the other complication of the airway that is not attended to. That's why we insist it should be covered. Because in the due course, you never know. In the beginning, as we are putting it, you never know there will be a communication. But it's better because the tumor is eating in all directions. If you put that covered stent with a cloth, covered with a cloth or membrane, it will be important that, because when we put it, we won't remove it unless it dislodges by itself. Okay. It is permanent. So we would wish to have that one, and not to prevent you putting, managing the other complication that may come.
interesting.
Yes.
So far you have talked about esophagectomy, where you cut out a portion of the diseased portion of the esophagus, and you patch up somehow. Then you've talked about the stent. What other modalities do we have?
Now, if these patients don't qualify for those two modalities, still the surgeon has a role to play. Sometimes we put what we call a feeding gastrostomy. What does it mean? We get a tube, a special tube, a feeding tube, strictly for feeding. We pass it here on the stomach, on the skin here, from the skin into the stomach straight. And we leave this part that we can no longer operate free with its mass. And then the other portion is the second mouth, artificial mouth. And that one you can put in smashed food, and then you can put in drinks, and even medication, and the rest, and then they go through the system. Okay. So the surgeon has a very big role, and the medical oncologists. Those are the people that give you the other chemotherapy drugs in the Cancer Institute, and then radiotherapy. Still, this patient would benefit from radio and chemotherapy drugs and other modalities that they may have. So those are some of the modalities that we use. And this patient continues to feed and continues to get other modalities of treatment, and his life pushes on. Yes.
Now, in the event that somehow fate has played on me and I'm maybe in stage 4.
Yes.
What would you do for me?
Stage 4. Stage 4 disease, we usually put that feeding gastrostomy.
Yes.
And we send these patients for chemotherapy and radiotherapy. Sometimes the oncologists I know also get a challenge when the body's immunity is quite very low. They may calculate for you what you are able to take. If your body is not able to take any medication, sometimes they may not give you any chemotherapy or radiotherapy, and they just leave you on other palliative treatment like morphine, which is a very good pain controller, and other things.
Palliation.
Palliation,
yes. Another key word you are using.
Palliate is
yes.
like to manage symptoms,
yes,
and to manage infections,
yes,
to manage pain and those other things that needs to be attended to in everyday life, where your quality of life is good, but your body is not able to take up other stronger medication, and you proceed until you meet your God.
Okay. So, Dr. Kabweru, you are telling us that yes, whereas at times fate plays on people, and we can't treat them, even doctors have limits.
Yes.
It is still possible to allow this person to live with the cancer of the esophagus, but without pain, when they are not losing weight, when they are not getting infections,
and they are eating,
they can interact with their loved ones till the Lord decides to call them. And I think that is beautiful. Yes. And we thank you for the work you do, Lord. So in the event that someone has maybe been diagnosed or they found that they have cancer of the esophagus, maybe in Masaka regional referral or in Hoima regional referral or something of that kind. What next?
Okay, thank you very much. Our unit or division of thoracic and vestibular provides services to patients. It carries out research, but also trains.
Where is the unit?
It is located in Mulago National Referral Hospital, Ward 2B CTS, and it is on level 2. And why I was discussing that we also provide a service to patients and do research, but also mentor people. So some of the people who have mentored are already in regional referral hospitals. I know, and some of the diagnostic tools are already available. So these doctors are able to see you, assess you, and see what modalities that you deserve at that level. In case they feel like they need to refer you, they will refer you to Mulago through casualty, and we can always admit you on our unit for any intervention. But in case they have seen you from the other side, I know that they are in a position, unless if things are not available or whatsoever, then you can always be referred to Mulago National Referral Hospital, and we work day in, day out, and you'll be attended to.
It has been a pleasure interacting with you. We thank you for the time you have given us. We have learned a lot about cancer of the esophagus. We've learned that the esophagus is this tube, if in simple terms, between the mouth and the stomach, after the mouth but before the stomach. We've learned about how cancer affects it. We've learned about the signs and symptoms, how we can diagnose it, the various complications, which were so many, and how it is managed, and anyway, where it can possibly be managed for. We would like to thank you so much for the time you have given us and for the valuable knowledge you have shared with us this evening. And certainly we cannot end with thanking our lovely and esteemed viewers for the time you have given us, for the various questions you have sent to us, for the interest you have expressed. The story does not end here. Let us continue being vigilant, interested in our health, and prioritizing our health above all else. I remain Dr. Muyanga and and this has been the Doc Talk Show.
The Doc Talk Show.
This message is from the Ministry of Health with support from partners.
UBC, inspiring Uganda.